Welcome back to another episode of Oncology for the Inquisitive Mind, featuring Josh, who is wearing headphones today because he decided to take things seriously. I joke, of course. Josh always takes this recording very seriously. But it sounds like he is having technical difficulties with his nondescript Apple products. Josh, auditory issues aside, how are you going today?
Oh, look, auditory issues ever aside, I'm doing well. It's been a nice morning, a little bit of admin, not too much clinic work, so that's always lovely. But we've got a pretty jam-packed episode planned, Dr. Michael Fernando. Would you love to tell our beautiful audience, who can also listen to us on YouTube and give us 5 stars if they like what Michael and I do, what we're doing this week?
Yeah, so we're continuing our sojourn into colorectal cancer, but we're going into the metastatic setting. And if you are someone who doesn't do a lot of colorectal cancer, Josh, you might think that this hasn't changed very much in the past 5 to 10 years. But I beg to differ, because when I was putting together the schedule for this series, I managed to very easily find several episodes worth of content. Still not quite breast cancer or prostate cancer levels, but this will be the first of several. And Josh is doing a little head bobby dance of triumph there. If you watch us on YouTube, you'll be able to see that in all of its bobbly glory. So we're going to talk about a couple of episodes, or a couple of very interesting studies on metastatic colorectal cancer today. And Josh, I'll let you start, because I say a couple, but I think on aggregate for today, we're going to be talking probably about 5 or 6 studies in total.
Yeah,
you did one of your characteristic deep dives.
I did. So the study that you suggested, Michael, it was all great, and then I got confused, and so I had to go do a little bit more digging, because you sort of have these standard of care approaches, and that's fine, but it's built on sort of almost half a generation of research. I think, is that a nice thing to say? It's like, it's not just one trial. It's kind of like a cacophony of trials. It's like, the symphony orchestra sort of playing, and then you finally figure out what they're playing. So we're talking about KRAS wild type tumors in the advanced colorectal space. And it looks like this has really developed over maybe the last 15 plus years, to say nicely. And so the study that Michael so kindly chose for me, and I know for our next episode, he chose the better trial, but look, I won't judge him, and I'll let him stay on the show because I'm a nice person.
You shouldn't have let me choose then.
I know.
Really, I'm victim blaming here is what I'm doing.
Yeah, exactly. So we're looking at cetuximab versus bevacizumab. I think that's nice to say. One's an EGFR inhibitor, one's a VEGF inhibitor. To put it nicely, one's vascular, one's works on the EGFR receptor. So the question was the effect of first-line chemotherapy combined with cetuximab or bevacizumab in overall survival in patients with KRAS wild-type, advanced or metastatic colorectal cancer. The background. Colorectal cancer is the second leading cause of death in America. This is an older study. It's at least 10 to 15 years old, but it's probably still up there.
I think it's still worldwide the third most leading, or the third most common, and something like the third or fourth leading cause of death, I think, behind lung and breast cancer.
Yeah, I mean, also one of those common cancers. So you'd expect that even if we have the most incredible drugs, or maybe not. But either way, so fluorouracil, the backbone of the world of metastatic colorectal cancer, developed in the 1990s, improved median overall survival from 12 to 15 months. But that's insane, right? Because 12 months is worse than essentially GBMs. Like it's worse than pancreatic cancers.
And it's about a third. It's about a third of what we would expect in the modern era.
Right, exactly. So, improvements have happened. Combination has shown to be even better with FOLFOXIRI, which is an oxaliplatin and irinotecan, or FOLFOX, which is leucovorin and oxaliplatin as well. So now the median overall survival at that point in time, it was about 10 to 15. Now it's about 18 to 20 months. So you can see there's already been a jump. Introduced cetuximab, which is a monoclonal antibody to the EGFR receptor, approved in combination with irinotecan or alone, following irinotecan failure for advanced or metastatic cancer. Bevacizumab, as I so eloquently mentioned, if I say so
Even
myself.
if you do say so yourself, yeah.
What can I say? Giving myself compliments already. I forgot my glasses, Michael, so forgive
You're giving
me
yourself 5 stars here, Josh.
I'm giving myself 5 Fernandos, thank you. It was a VEGF inhibitor, also approved in the familial cell space. The question that we have, what is the optimal biologic monoclonal antibody chemotherapy combination? So this trial was the addition of cetuximab or bevacizumab to FOLFOX6 regimen or FOLFIRI regimen, and which one is superior in the first line for KRAS wild type. Enter the year, September 2005. Chemotherapy plus cetuximab. I should put my eloquent Michael was a baby at this point in time comment, so we've said it.
It's true.
I was a mere man with a recently groomed beard. Not beard, one of those like mustaches that you get in like high school.
I cannot imagine you with a beard, Josh.
Can't grow one. Wish I could.
No, that's the main reason why.
So you're given chemotherapy plus Cetux, chemotherapy plus bevacizumab, or chemotherapy plus Cetux and bevacizumab. It was amended after 3 years, and that combination of both the drugs was ceased. So it was closure of the dual antibody group. I suspect either toxicity or lack of efficacy, but probably tox, I'm guessing. So over 4 years, patients were randomized between the 3 arms, then reduced to 2 arms. They are stratified based on chemotherapy regimen, receipt of a prior chemotherapy, and prior pelvic radiation, which we don't really do anymore at all.
Unless it's rectal cancer, which at this point in time probably would have been broadly just lumped together.
Exactly.
With colon cancer.
Yeah, and so primary endpoint was Michael. Now, primary endpoint was overall survival. Secondary endpoint was response rates and progression-free survival and 60-day mortality. They were recruited between 2005 and 2012, so like a slow recruiting study, but there were 2,334 patients that were randomized. So this is like breast sizable trial. And about 1,100 patients were then 1,100 patients were KRAS wild type. I will now go ahead and show that design. If you can see, for all those beautiful listeners on YouTube, there it is. There is a lot of writing here, but essentially it talks about who died, who withdrew, other disease, etc., etc. And then if you go to the next slide, this is just looking at the overall survival. I'll get into this in a little bit more detail, Michael, of the KRAS wild type when you're comparing the arms. There wasn't actually a difference between the two. And then you look at the overall survival and the expanded RAS analysis. Again, you can see there was it was non-inferior at this point in time.
What a fantastic RAS analysis you did there, Josh.
Thank you. I'm a razzmatazz. So the patient outcomes, those confirmed with KRAS wild-type tumors, the median overall survival is 30 months in the Cetux arm, 29 months in the bevacizumab arm, with a hazard ratio of 0.88. There was not statistically significant. The progression-free survival was 10.5 months in the chemotherapy Cetux group and 10.6 months in the bevacizumab group. So it's all a bit inconclusive, or I guess it's non-inferior in this specific study that sort of we chose. The combination of chemotherapy and surgery rendered 140 patients disease-free. The median overall survival for the bevacizumab group was 62 months and 64 months in the Cetux group. This is at a time when we still use these in the sort of not peri-op space, but potentially resectable space. But if the summary of that is only 58 patients were alive at the end of the analysis. So this particular trial, so there was no difference between the initial biologic. And I think this was from memory in all comers, initially the trial, figuring out what. But it gets a bit more interesting, and this is why I've dived into slightly other trials, because, get yourself confused a bit. You're like, okay, so that means Cetux and bevacizumab are non-inferior, so then can you just interchange them? That is not the case. Bring in the crystal trial, my crystal ball. So it was first-line cetuximab was explored in the Crystal trial, where just under 1,200 patients with untreated metastatic colorectal cancer were assigned to FOLFIRI with or without Cetux. You might be like, why not FOLFOX, Josh? Well, they're non-inferior. And the other thing is that depending where you live and work in the world, your institution and your country will have a different preference between oxaliplatin and irinotecan.
It's very accurate, Josh.
Thank you. I know.
I mean, you talked about, Bev and Cetux not being interchangeable. Folfox and Folfiri in the first line, they really are. All the evidence is that they're pretty much equivalent.
Exactly. So the median progression-free survival was modestly but significantly better with cetuximab. So that was 8.9 versus 8 months. Like, this is small cell atezo sort of style.
The word modest is doing a lot of heavy lifting there, isn't it?
Right. But the overall response rate was better. So it's 47 versus 39%. And interestingly, it did not translate into a significant overall survival benefit. But wait, there's more. Subsequent report among those with wild type KRAS patients, response rates were significantly higher in those in the Cetux group. So I think this was an all-comers. And then again, they've done an analysis. So this time it was 57 versus 40%. So almost a 20% benefit of having cetuximab, and was with a median PFS and OS being that of 23.5 versus 20 months. So there was benefit there as well. Adverse events was present, but not much, about 5% more. Okay, and then you're seeing skin toxicity being more, which is quite a common Cetux panitumumab issue. Moving on to another trial, because I think this is the growth of this space. You've got the Tailor trial. It was a Chinese trial, but against cetuximab, but it was in China. Folfox with or without Cetux. It improved PFS with a hazard ratio of 0.69. So that's showing, almost a 3-month benefit, and overall survival was also significant of about 2.5 months. The trial that I did want to actually really talk about, which was the FIRE3 trial, which had the final follow-up in 2021. So we've gone from 2005, when Michael was but a wee warthog, to 2021, which he was a bigger warthog.
Did you just call me a warthog?
I did. It's a saying. It's a saying.
Is it though? Or is it a Joshism?
It's a Joshism. But
Yeah.
look, I have lots of Joshisms, and ism is the Josh. So what they found from this trial, the median survival was 30 months in patients who had cetuximab, and most of them had 5FU backbone. The design for this trial, so you can see now from 2005, from that initial trial where, it was 12 to 15 months, now to 2021, we pushed that to 30 months, right? The randomized trial, phase 3, Cetux and bevacizumab, when added to first-line fluorouracil, plus folinic acid and irinotecan, so FOLFIRI in this particular case, in those with a KRAS wild-type metastatic colorectal cancer. This is the one where you've actually extracted the KRAS up front. The overall survival is longer in the intention to treat. That's the summary. But I do have a slide to show, because I am that kind of guy.
Please hold.
Please hold as slow Josh does it. Here we go. So 752 patients previously untreated, randomized to Cetux plus FOLFIRI or bevacizumab plus FOLFIRI, with the primary endpoint being objective response rate and the secondary endpoint being everything you know and love on this show: overall survival and progression-free survival. So when we look at the data points, the median follow-up was 71 months. I've jumped to the end of this trial. At the time of analysis, 82% of the FOLFIRI Cetux patients had died, and 90% of the FOLFIRI Bev had died. But there was still 18% of people who were still alive at 71 months. So that is not an insignificant number. It was significantly longer at the 3 and 5 year mark, being 43 versus 33%, and then 18 versus 9%. So you're doubling overall survival by tailoring treatment to those that were KRAS wild type. The median overall survival was 31 versus 26 months, and the survival benefit was limited to those with left-sided tumors with a hazard ratio of 0.7, but was no different when you look at right-sided tumors. Important. Intention to treat, median, which is, I think, the cohort, median overall survival was 27 versus 26 months, and the objective response rate, you saw about a 12% benefit adding cetuximab. median progression-free survival, I think, was somewhat similar between groups, but overall, when you look at the tailored left-sided KRAS wild type, there was a definite benefit in that cohort of patients. And it sort of correlates to when you look at sort of up-to-date in guidelines, they sort of say left-sided, and Michael, correct me, because you are the colorectal aficionado out of the two of us, at least. It seems to be more favored in left-sided KRAS wild type.
Very much so. Very much so. And it's largely based on this data.
Cool. So how did I go? Did I pass?
Full marks, 5 out of 5.
Fernando's?
Yes.
Great. Well, that was 15 minutes or less for 15 years or more. Michael, what are we talking about today for you?
Yeah, so my collection of studies is going to be probably far briefer, and it's not going to average out at 1 minute per year. But, going on, building on from the question about biologics, bevacizumab versus cetuximab, we mentioned about FOLFOX versus FOLFIRI. But what about the question of combining those two with a regimen called FOLFOXIRI? Because, we're just so creative in the oncology world and these acronyms. Now, for those who are listening who don't do a lot of colorectal cancer, you might have seen FOLFOXIRI in young patients who have a very high volume of disease, who are otherwise fit, and so can tolerate the expected increase in toxicity. But what's the data behind this? So I'm going to whiz through a couple of them and then talk about the triplet trial, or the triplet trial, because there's an E on the end, that I think is fairly interesting and worth discussing. So the background to this is that in 2014 there was a study by Lupakis and colleagues that did demonstrate a PFS and overall response rate benefit for FOLFOXIRI versus FOLFIRI with bevacizumab in both cohorts. However, there was no overall survival benefit. For reference, the PFS difference was about 2 to 3 months. The overall response rate difference was about 12%. But while there was a numerical benefit, 31 versus almost 26 months, it did not reach statistical significance. Then there was a Cochrane meta-analysis in 2020 that did find a significant improvement in outcomes, specifically overall survival. Now, the numbers in this meta-analysis were almost 29 months for FOLFOXIRI versus 24 and a half months for FOLFIRI, or FOLFOX chemotherapy. And there was no significant heterogeneity among trials. If you can hear that in the background, that's my dog. He's very angry that he's been left outside, so apologies for the soundtrack. There was also a statistically significant PFS and overall response rate benefit as well. However, as you would expect, there is a higher toxicity rate, with specifically with grade 3 to 4 neutropenia, febrile neutropenia, and diarrhea. Now, so FOLFOXIRI plus Bev is an accepted regimen. It's not commonly used in this space because there's always the question about toxicity, and there's always a question about what you use afterwards. So there's a lot of, re-challenging of FOLFOX, FOLFIRI, all that sort of stuff, if you use FOLFOXIRI first line. But the logical extension to that is, what about biologics? What about anti-GFRs? What about, in this case, in the triplet style, panitumumab? And again, following on from FIRE3 and all of the 15 years worth of evidence that Josh summarized so well, this is for RAS-RAF left-sided tumors. So we're excluding everything from right side because, there is the FIRE3 data that shows that right side doesn't respond anywhere near as well. Right-sided is also much more likely to have something like a BRAF mutation, and there's evidence that EGFR inhibitors don't work so well with patients with BRAF as well. So the triplet study is an Italian study, and it enrolled 435 patients, and it assigned patients to either FOLFOX plus panitumumab or FOLFOXIRI plus panitumumab. About 435 patients were enrolled in total, so you're looking at about 215 in each group. The primary endpoint was overall response rate, which I always think is a bit of a weird thing for a primary endpoint in metastatic disease, because you're not really interested. I mean, you are interested in a response rate, but you are more interested in survival outcomes. And
It's
so
funny. My trial was the same.
yeah, I was going to mention that.
Yeah.
It's interesting, and I don't think it's like a colorectal specific thing.
When was the trial
So
recruited?
the final analysis. So I don't know when it was recruited. I think it was late 2010s. The final analysis only came out earlier this year.
You do see sort of swings and roundabouts when it comes to trial design, and I wonder if it was a bit of a hedging your bets when it came
Maybe a bit of a fad. Yeah, that's
Maybe.
true.
Who
That's
knows?
true. But it is something to consider because 435 patients, while that's a lot for our sort of standards, I guess, in terms of studies, it does sort of make it a bit harder to analyze secondary endpoints, which in this case were PFS, safety. They had early tumor shrinkage, which they defined as the percentage of patients achieving a greater than or equal to 20% decrease in the sum of diameters of the RECIST target lesions. They also talked about R0 resection rates and overall survival. All of that stuff is going to be harder to analyze if you have 430 patients compared to if you have, in one of your studies, Josh, you had more than 2,500 patients. So it's going to be harder. So that means that this extra data you have to take with a larger grain of salt. In terms of the demographic notes, 100% of patients were Caucasian. It's an Italian study, so that's something to keep in mind. 82% of patients were ECOG 0, so which fits with the people who you would consider giving FOLFOXIRI. 88% had presented with synchronous metastases, and despite them saying that patients who were enrolled had left-sided primary tumors, only 88% of them did have a left-sided primary tumor. So that's something else that you've got to keep in mind. You wouldn't really use panitumumab in a right-sided tumor. It's also worth saying, and this is a very minor point, that what constitutes left and right-sided colorectal cancer is a bit up for debate. No one can really agree on where the transition point between left and right is. Some people say it's midway through the transverse colon. Some people say it's at the splenic flexure. So this left-sided, right-sided dichotomy, it's probably not as black and white as we make it out to be. So the results, and I think that I will just open this thing because, I was trying desperately to be smoother than Josh and have failed miserably.
Yeah, that was almost as bad as me. So well done.
Almost as bad. But as you can see, there's no real significant difference in overall response rate, which was the primary outcome. In fact, numerically speaking, the control group of FOLFOX plus panitumumab actually did better. 76 for the doublet versus 73 for the triplet. The early early tumor shrinkage. Sorry, I had ETS in my notes here, and then I just momentarily forgot what it stood for. The early tumor shrinkage rate was very similar again, 57 against 58%. The R0 resection rates and the progression-free survival, all very similar, and more significantly, literally speaking, none of them were statistically significant. As you would expect, the safety was worse in the triplet group, with higher rates of grade 3 to 4 adverse events, 69 versus 57%, with more frequent neutropenia, diarrhea, and fatigue.
Michael,
and so
sorry, interrupting you again, but
classic,
good segue moment. How do you interpret the next line?
Oh,
that's my question. That's what I actually want to know because so go on.
You beat me to it. I had a segue all ready to go, and then you just beat.
I guess we do this too often.
We really do.
The reason I bring it up is like when I did colorectal, and I did do some colorectal in my lifetime. This was always a debate. This regiment was a debate, and we did use it. I mean, I also had a very fit young cohort of patients where potentially resectable, and you wanted to kind of hit them super hard. But I'd love to know the next line you're about to say, so listeners, stay tuned to what Michael's beautiful voice is going to come out of his vocal cords next.
That's a weird way to say it, Josh. But
I know.
But yes, So the summary is, and yeah, what I was about to launch into is this is why I thought this trial would be interesting, because what they have actually found in the final analysis, which came out earlier this year, is that there is a statistically significant, you might, for our YouTube viewers, you might be able to see the p-value up in the top middle there, by the skin of its teeth, statistically significant overall survival benefit for FOLFOXIRI plus panitumumab. It is 41.1 versus 33.3 months with a hazard ratio of 0.79. And for our auditory listeners on Spotify and Apple Podcasts and wherever else you get your podcasts, the p-value was 0.049. Now, all subgroup analyses cross the line of equivalence for this, and I don't think with this sort of study you can take very many conclusions from subgroup analyses. The morphology of the Kaplan-Meier curves, which we've got up here, is also very interesting. There's no difference for the first 2 years, and it's only at about 24, 25 months that the two curves start to separate in favor of the FOLFOXIRI panitumumab, which raises a lot of questions in and of itself. But it does make you wonder whether the people who do better in the FOLFOXIRI arm, I mean, there's got to be some sort of confounding factor here, or some additional contributory factor. The authors even said in their discussion they have no idea how this has happened, because normally it is the other way around, that we have benefits in overall response rate and progression-free survival and R0 response rate. We see the R0 resection rate, and we see this in colorectal cancer, but none of those factors contribute to a benefit in overall survival. It's very rare that we have the flip side. So this is a bit of a conundrum, and you wonder about patient selection, patient fitness, other factors. The mutational status of these patients. Are there other things? And we'll come to a later episode about PIK3 kinase and aspirin. Were more people in the experimental group taking aspirin or NSAIDs? Who knows? But it is a very unusual outcome. Now, interestingly as well, we've also talked about post-progression survival, because they did drill down and look at whether this was a sustained thing, or whether patients dropped off very quickly after progression. And I guess this is important, particularly for FOLFOXIRI, because as we said before, you don't really have very much else short of Lonsurf, fruquintinib, and a re-challenge of one of the regimens upon progression. And there are, of course, a million factors that can go into that. Did they progress on FOLFOXIRI, or was it after the oxaliplatin, which was dropped, which is usually after 9 to 12 cycles? But the post-progression survival was actually higher in the FOLFOXIRI arm as well. Admittedly, not statistically significant, but 24.6 versus 17.7 months. Similar proportions of patients received subsequent lines of therapy, as I will show in this Sankey plot here, which I think is just the coolest, most confusing thing ever. But you can see by the thickness of the curves here for our YouTube viewers that there were similar rates of subsequent therapy and different subsequent therapies across both groups. Patient had similar exposure specifically to regorafenib, Lonsurf, and anti-EGFR treatment, but you're really dealing with lots of re-challenges. But the long and the short of it is, it's a very interesting study, but more for what it showed rather than the answers that it gives. So to summarize here is that what I've said is that FOLFOXIRI plus Bev, because remember this is FOLFOXIRI plus panitumumab, is the more robust regimen. If you're going to go with a triplet, go with that, because there are fewer questions. We've got a meta-analysis level data that shows that it is, for selected patients, and you've got to select your patients properly here, that it is better from an overall survival benefit. FOLFOXIRI plus an EGFR is difficult to recommend on the basis of these results. They're just too incongruent. And I think this is the sort of thing where a repeat study in a different cohort with, modern genomic ctDNA analysis would be really interesting. No subgroups seem to benefit particularly well for the triplet over the doublet. You could consider it in young, motivated patients, but we have so such easy access to bevacizumab now that I really don't think that there's a situation where you would choose that over or you would choose an EGFR over bevacizumab.
There you go, Michael. Look at that. The long and the short of it by Michael Fernando. You should start one of these do this trial again at the PA. You can be the king of colon cancer. Colon king, as they call you.
Well, yeah, that's what all my friends call me when I, go out for parties and stuff. But I think that's not something that I do. But I think it would be. It's a tricky study. I think any study involving FOLFOXIRI is tricky because of the cohort selection.
Of course.
And I think that with aging populations and increasing comorbidity, despite the fact that more and more young people are having colorectal cancer these days, I think it's still going to be a very difficult regimen to retest. But look, the summary of this is: if you're first line RAS/RAF wild type, left-sided, do a doublet with EGFR. If you really want to go a triplet because you're chasing that overall survival benefit, do it with Bev. But select your patients.
Well, you heard it here you heard it here first from the colon king himself. Michael, next week we continue with the colon king's favorite topic, colorectal cancer. Are we doing more metastatic?
It'd be a twist if you then turned around and said my favorite topic was breast cancer. Although the whole colon king thing is very disconcerting. But yes, we're continuing colorectal cancer, and basically we're looking at the main mutational subtypes for colorectal cancer, the sort of thing that you're going to come up with in your new patient clinics. And the first step is dMMR, metastatic colorectal cancer. Now, we talked about early with niche 2 and the idea of neoadjuvant immunotherapy, which is a fascinating, probably a bit premature approach, but the metastatic setting is much more well established. And we're going to talk about 2 studies, Keynote 177 and the more recent Checkmate 8HW.
I'm looking
very interesting.
Yeah, I'm looking forward to seeing the Fernando waterfall plot. We'll see you then.
We'll get there. Take care. Thank you for listening to this episode of Oncology for the Inquisitive Mind, produced by ADC Productions, with the assistance of education grants from Pfizer and Merck Pharmaceuticals. As always, these companies do not receive early previews or editorial input of any kind. The opinions expressed in this episode are our own, and the facts are, well, the facts. If you liked this episode, please consider subscribing to be among the first to hear our latest forays into the ever-changing world of medical oncology. You can find previous episodes of our show, including coverage of major conferences, interviews with world-renowned experts, and much more at inquisitiveonc.com. If you would like a particular subject covered on the show, drop us a line at inquisitiveonc@gmail.com. And if you happen to be in Australia, stay tuned for details about exciting in-person events we have planned for the near future. Thanks for listening, and we look forward to demystifying oncology again next time.